Okay, let's unpack this. Imagine a crucial set of one-way gates inside your body, regulating a constant vital flow. These gates open and close about 100,000 times a day, every single day, for decades. That's over 2.5 billion times in an average lifespan. And yet, for most of us, they never miss a beat. It's kind of amazing.
It really is staggering when you think about the mechanics.
So this deep dive is all about those incredible structures. The heart's valves. We'll explore their ingenious design, the surprising ways they can go wrong, and the astonishing journey of human ingenuity to fix them. You know, from what was once considered truly reckless surgery to today's cutting-edge interventions.
Exactly.
Our mission today is basically to give you a shortcut to being truly well-informed about these vital heart structures.
And what's fascinating here is that, given the sheer workload these valves endure, the reported prevalence of serious cardiac valvular heart disease is actually less than 2% of the population.
Less than 2%. Wow.
Yeah, it truly is a testament to how exceedingly well adapted these structures are to meet such continuous physical demands. But, and this is the important part, when injury or degeneration does occur, the consequences can be, well, significant.
Right, leading to serious illness.
Serious illness, even death. So our goal today is to help you understand not just what happens when these vital structures falter, but why it matters. And also how medicine has risen to this incredible challenge over the past century, bringing extended life and improved health to millions.
Okay, so you painted a picture of these valves as vital one-way gates. Let's really open up that picture. How do they actually work? What are they called? And what's their unique job in keeping blood flowing, just right through our heart's incredible plumbing?
Sure. So at its core, the heart contains 4 one-way valves. Each one is strategically placed to regulate the precise directional flow of blood. We basically categorize them into 2 main types based on their location and function.
Okay.
First, you have the atrioventricular valves, or AV valves for short.
AV valves, right.
These are the mitral valve on the left side of the heart and the tricuspid valve on the right. Their primary role is, to act like trapdoors. They seal shut during systole. That's when the main pumping chambers, the ventricles, contract.
Okay, when the heart squeezes.
Exactly. This stops any backward flow of blood into the upper chambers, the atria. And this is absolutely crucial for building up the pressure needed to send blood forward.
Makes sense. No leaks allowed.
Precisely. Then we have the semilunar valves.
Similar.
So are the aortic valve on the left side, which sends blood out to the entire body through the aorta.
The big one.
The big one, yeah. And the pulmonic valve on the right side, sending blood to the lungs via the pulmonary artery. Now, these valves do the opposite of the AV valves. They close during diastole.
So when the heart is relaxing.
That's right, when the heart is relaxing and filling with blood. This action maintains high pressure in those big arteries, the aorta and pulmonary artery, ensuring blood is ready to be efficiently pumped out with the next beat. If we, connect this to the bigger picture, it's all about creating and maintaining these precise, stepwise pressure gradients.
Stepwise pressure.
Yeah, differences in pressure between chambers. They're absolutely essential for the heart to pump blood effectively throughout your entire body. Without them, blood would just sort of slosh back and forth. You'd lose all efficiency, like a pump trying to work with leaky seals.
It's incredible to think about the sheer number of times these structures open and close. Billions of times. And the constant pressure they're under. So how are these incredibly hardworking gates built to withstand all that?
Yeah.
What gives them their remarkable resilience?
Well, their strength and resilience come from a really highly organized, layered structure. It actually starts forming very early in our development. All 4 valves are supported by these internal plates of dense connective tissue. And these are continuous with what's called the heart's fibrous skeleton right at the base of the heart.
Fibrous skeleton. Like a foundation.
Exactly like a foundation. Think of it as the heart's sturdy framework, providing an integrated, robust structure for the valves to attach to. And you have to imagine these valves aren't just simple flaps. They're intricate, layered structures, almost like a high-tech fabric.
High-tech fabric. How so?
Well, they have distinct layers. There's the fibrosa, which is mainly dense collagen that provides the structural integrity, the toughness.
Okay, the strong part.
Right. Then there's the spongiosa, which is made of proteoglycans. This acts like a shock absorber, cushioning the impact of closing billions of times.
Like padding.
Sort of, yeah. And then there's an elastin layer. It's called the ventricularis on the semilunar valves, or the atrialis on the AV valves. This forms the surface where blood flows smoothly. So you've got strength, shock absorption, and a smooth surface all layered together. It's designed to be both incredibly strong and incredibly flexible.
That makes sense. Tough but bendy.
Pretty much. Now, despite this general layered structure, the semilunar and the atrioventricular valves actually look and function quite differently, which is, well, fascinating.
How so?
The semilunar valves, the aortic and pulmonic ones, they're sort of freestanding structures. They sit right atop the outflow tracts of their ventricles and attached to the walls of the big arteries. They get their name, semilunar, from their shape, like little half moons. Each valve typically has 3 of these cusps.
3 cusps, okay.
During diastole, when the heart fills, these cusps simply fall passively towards the center, like pieces of a well-fitted puzzle. Their edges meet and seal the opening, preventing backward flow. It's a very elegant passive closure.
Passive closure, interesting. So they just fall shut.
Essentially, yes. Now, contrast that with the atrioventricular valves, the mitral and tricuspid. These are part of a much more complex functional valve complex.
A complex? What makes them complex?
Well, they aren't freestanding. They have these distinct fibrous rings at their base, the annulae fibrosus. From these rings arise the valve leaflets themselves. The mitral valve usually has 2 main leaflets, anterior and posterior, while the tricuspid typically has 3.
Okay, 2 versus 3 leaflets.
But what truly sets them apart is their intricate support system. They have these fibrous chordae tendineae.
Chordae tendineae, those are the heartstrings, right?
That's what people often call them. They look like tiny strings or parachute cords attaching to the leaflet edges. And these chordae then anchor down to robust, finger-like projections called papillary muscles. These muscles arise directly from the heart muscle itself, the ventricular myocardium.
Okay, so strings attached to muscles.
Exactly. And these papillary muscles are absolutely crucial because during systole, when the ventricle contracts, these muscles also contract. They pull on the chordae. This action dynamically tethers the leaflets in their closed position. It stops them from prolapsing or bulging backward into the atria when the ventricles are squeezing under high pressure.
So it's an active process, not passive, like the other valves.
Precisely. It's an active, synchronized closure mechanism, making them much more elaborate structures than the semilunar valves.
It's easy to take modern heart surgery for granted, isn't it? Especially with the incredible precision we see today. But the very idea of repairing these tiny vital structures, it was once seen as utterly outlandish, even reckless.
Completely.
Let's trace that incredible, sometimes fraud history of heart valve surgery. It almost sounds like science fiction that these operations were even attempted back then.
Indeed, the early days were marked by incredible bravery, immense ingenuity, and not a small amount of controversy. The concept of intervening on the heart valves actually dates back further than many people realize. Think about Sir Thomas Lauder Brunton. He was a Scottish physician who, way back in 1902, remarkably proposed a closed repair technique for a narrowed mitral valve, what we call stenotic rheumatic mitral valve disease.
1902, wow. How did he plan to do it?
His idea was to access the valve by passing a dilator through the left ventricular wall.
Through the heart wall?
Yeah, but his colleagues at the time actually shunned this. They called it reckless, and it was never clinically attempted.
Understandable, I suppose. That sounds terrifying.
It really illustrates the initial resistance and the sheer boldness required for such invasive procedures in that era. Imagine the medical conservatism.
So his idea just died?
Fortunately, no. Brunton's theory didn't die there. Fast forward to 1923. You have Elliot Cutler and Peter Levine working in the research labs at Peter Bent Brigham Hospital in Boston. They further developed his ideas. And after extensive lab experimentation, they successfully performed what's considered the first surgical correction of the mitral valve.
Ah, so they actually did it.
They did. This was a true birth of evidence-based surgical innovation. Then, a couple years later, 1925, Henry Suttar in England adapted their technique. He reported the first successful closed digital commissurotomy.
Closed digital. Does digital mean what I think it means?
It does. Get this. He literally inserted his index finger through the left atrial appendage to mechanically dilate the narrowed mitral valve.
He used his finger inside the heart.
Inside the heart. While pioneering, this procedure wasn't widely adopted until much later, around 1948, after more widespread reports of success by American surgeons like Charles Bailey and Dwight Harkin.
Still, just incredible bravery. What about the aortic valve? Was that attempted too?
Yeah. Blinded aortic valve surgery followed a similar challenging path. There were early, less successful attempts. Theodore Tufir in Paris tried in 1912, basically pushing his finger against the aorta to kind of invaginate the wall through the valve.
Wow.
Russell Brock in London tried mechanical dilation with an instrument in 1940. These didn't really gain widespread acceptance, but they definitely paved the way. Then Horace Smithy in Charleston, South Carolina, performed the first successful aortic valvotomy in 1948. And 3 years later, Charles Bailey reported success using a transventricular expanding dilator.
So these were all blind procedures, working by feel.
Pretty much. Extraordinary acts of courage and foundational steps, absolutely. Even if they lacked the precision we expect today. It's almost hard to imagine the courage it took, knowing the stakes were so incredibly high with every single movement inside a beating heart.
Here's where it gets really interesting, though, because it sounds like a lot of trial and error, a lot of procedures where surgeons were literally working by touch with very limited visibility. So what were the actual game changers? The monumental advancements that truly launched the modern era of open heart surgery, allowing surgeons to finally see what they were doing and achieve more consistent results.
You're right. The mid-20th century saw two truly revolutionary advancements that quite literally opened up the chest to modern heart valve surgery. The first was the development of a viable prosthetic valve.
An artificial valve.
Exactly. In 1952, Charles Hufnagel at Georgetown University performed the first successful implantation of a prosthetic valve. And crucially, he did this without using cardiopulmonary bypass, which wasn't widely available yet.
How did he manage that?
It was a really clever workaround. Given the inability to safely access the aortic valve in situ at the time, he implanted a caged ball valve, this early type of mechanical valve, into the descending aorta.
Not in the heart itself.
No, further down the main artery. It was for patients suffering from aortic insufficiency, a leaky aortic valve. It wasn't perfect, but it was a bold, imaginative step, putting a man-made part into the human circulatory system to solve a critical problem.
Okay, so that's one piece. What was the other?
The second, and arguably the most monumental advancement, was the advent of cardiopulmonary bypass.
The heart-lung machine.
That's the one. This technology allows a patient's blood to be circulated and oxygenated outside the body, effectively taking over the functions of the heart and lungs temporarily. Gibbon achieved the first successful clinical use of this in 1953. This was a true game changer.
Because surgeons could stop the heart.
Precisely. It allowed surgeons to stop the heart safely and operate directly on the valves, finally being able to see what they were doing with clarity and precision. Imagine the difference for a surgeon. Going from working by touch and a constantly moving blood-filled organ to having a motionless, relatively bloodless field where they could see every detail. It was night and day.
So you have the artificial valve, and you have the ability to stop the heart safely.
And the combination of those two innovations truly sparked the explosion of modern heart valve surgery. Dwight Harkin, building on his earlier work, completed the first successful in situ aortic valve replacement in 1960. He used a caged ball device to replace the patient's diseased native valve.
Right inside the heart this time.
Yes. And that same year, Albert Starr and Lowell Edwards out in Oregon successfully replaced the mitral valve with a similar caged ball prosthesis they had designed. This combination, being able to stop the heart and having artificial valves to implant, led to this incredible cascade of improvements. Better valve designs, refined surgical techniques. It allowed for progressively better patient outcomes and truly launched the era of complex valve repair and replacement surgery that we know today.
Okay, so we understand their amazing design and the incredible history of how we learned to fix them. But let's get back to the basics of what goes wrong. What are the main ways these vital structures can actually be compromised? What goes wrong fundamentally with the valves themselves?
Right. So the cardiac valves, despite their inherent resilience, can suffer from two fundamental forms of dysfunction. And often you actually see a significant overlap between the two.
Okay, what are they?
The first is stenosis. This basically means the valve doesn't open completely. It creates an obstruction to forward blood flow.
Like a sticky door.
Exactly. Think of a sticky, narrow door that just won't open fully, forcing everyone to squeeze through a tiny gap. Stenosis is almost always caused by a primary problem with the valve leaflets themselves. They get stiff, calcified, thickened over time due to some chronic disease process.
Okay, stenosis, incomplete opening. What's the second type?
The second fundamental dysfunction is insufficiency, which you also hear called regurgitation or incompetence.
Leaky valve.
That's the common term, yeah. It describes backward flow of blood through the valve when its cusps or leaflets fail to close properly. Imagine that door not closing all the way, allowing blood to leak back through even after it's been pushed forward. Now, regurgitation can happen suddenly, that's acute, or it can develop gradually over time, which is chronic. And it can be a problem with the valve itself, which we call primary regurgitation. Or it can be secondary to issues with the surrounding supporting structures.
Like what?
Things like the main arteries dilating, problems with the valve's supporting ring, the chordae tendineae, the papillary muscles, or even the ventricular muscle itself getting too big or distorted.
So the valve is okay, but its surroundings are messing it up.
Exactly. And understanding this distinction, primary versus secondary, is really key because the cause often dictates the best treatment approach.
Makes sense. So what are the most common causes of these dysfunctions? Do they vary much?
They vary significantly across the globe, actually. Despite a decreasing trend in developed nations, rheumatic heart disease, RHD, still remains the most common cause of valvular dysfunction worldwide, especially for mitral stenosis, that narrowed mitral valve.
Rheumatic heart disease, that comes from strep throat.
Essentially, yes. It doesn't start in the heart itself. It develops from a cross-reactive immune response in people who are genetically susceptible, following a group A strep infection like strep throat, usually acquired in childhood. It's a phenomenon often called molecular mimicry. Basically, the immune system gets confused and mistakenly attacks the heart valves, leading to inflammation and scarring over time.
So your own immune system damages the valve.
That's the mechanism. And chronic RHD often develops silently from ongoing valvular damage due to repeated strep exposures, plus the constant hemodynamic stress on an already deformed valve. This leads to hardening, or sclerosis, reduced leaflet mobility, and often results in a mixed picture. The valve is both narrowed and leaky.
What does it look like?
The classic appearance of a valve badly affected by chronic RHD is often described as a fish mouth funnel valve lesion.
Fish mouth.
Yeah, because of the severe fusion and shortening of its leaflets and those supporting chordae tendineae. It looks puckered and narrowed. While it most commonly involves the mitral valve, RHD can also affect the aortic valve. And it can cause the tricuspid valve to leak secondarily because of the increased pressure it creates upstream in the lungs.
Okay, so RHD is big worldwide. What about in developed countries like the US or Europe?
Moving to the developed world, degenerative disease is by far the most common cause of valve disease, particularly for aortic stenosis, that narrowed aortic valve.
Degenerative. Is that just wear and tear from aging?
It used to be called senile disease, suggesting that, but we now understand it's much more complex. It's actually an actively regulated biological process, strikingly similar to atherosclerosis, the hardening of arteries.
So like cholesterol buildup.
Sort of. Over time, factors like turbulent blood flow cause injury to the valve tissue. This kicks off a cascade of events. Lipid accumulation, immune cells move in, and crucially, cells within the valve transform into bone-like cells, leading to calcification.
Bone forming on the valve.
Essentially, yes. Calcification of the aortic leaflets, making them stiff and rigid. Sometimes it can affect the mitral valve and its surrounding ring, too.
And what about those bicuspid valves you mentioned?
Ah, yes, bicuspid aortic valves. They are a significant contributing factor to degenerative aortic stenosis. These are congenital, you're born with them. They affect about 1–2% of the population, making them the most common congenital heart valve lesion.
Instead of 3 cusps, they only have 2.
Right. And these valves tend to degenerate and calcify much earlier than normal 3-leaflet valves, maybe 2 decades earlier, often peaking in a person's 50s or 60s.
Wow.
It's believed to be due to increased hemodynamic stress on their abnormally shaped leaflets. The flow dynamics are just different and put more strain on the valve tissue over time.
Okay, so that covers stenosis causes.
Yeah.
What about leaky valves, regurgitation? You mentioned mitral regurgitation is common.
Yes. Mitral regurgitation, MR, a leaky mitral valve, is actually the most frequent type of valve dysfunction overall. In fact, a tiny, trivial amount of leak is present in most healthy adults. But significant MR is the second most common valve problem needing surgery.
And you said there's primary and secondary med over.
Correct. When we talk about MR, we differentiate between primary MR, where there's a structural issue with the valve itself, and secondary or functional MR, where the valve leaflets are actually fine, but their supporting structures are distorted.
So what causes primary med-off?
For primary MR needing surgery, the most common cause is degenerative changes. A common type of this is myxomatous disease, sometimes called Barlow disease or Klick-Murmer syndrome. Here, the valve tissue becomes thickened, floppy, and weakened. It results in redundant, billowing valve leaflets that prolapse or bulge backwards into the atrium when the heart pumps.
Like a parachute that's too big.
That's a great analogy. It billows excessively. This typically affects younger women more often. Other causes of primary MR can be things like fibroelastic deficiency syndrome, seen more in older patients, where the leaflets are thin and a chordae tendineae might rupture suddenly. Or mitral annular calcification, MAC, calcium buildup around the valve ring, usually benign but can cause mentor. Or even coronary ischemia, a heart attack damaging a papillary muscle, causing acute severe MRR.
Okay, that's primary med-off. What about the secondary or functional type?
Right. Secondary or functional MR is not caused by a problem with the valve leaflets themselves. Instead, it results from distortion of the whole heart chamber, the left ventricle. This usually happens after a heart attack has damaged the heart muscle or due to a cardiomyopathy where the heart muscle is weakened and enlarged.
How does that make the valve leak?
When the main pumping chamber, the left ventricle, dilates, it stretches everything out. It pulls the papillary muscles, those anchors for the chordae, outward and downward. This tethers the leaflets, pulling them apart so they can't meet properly in the middle to seal during systole. You get a central leak. The valve itself is healthy. It's the sick ventricle that's pulling it apart.
Fascinating distinction.
Yeah.
Okay, what about the aortic valve leaking aortic insufficiency?
Right. Aortic insufficiency, AI, or aortic regurgitation. This can happen if the aortic valve cusps themselves prolapse, similar to mitral prolapse. But more commonly, it results from dilation or widening of the main artery leaving the heart, the aortic root.
The area gets too wide.
Yeah. When the aortic root stretches, even if the valve leaflets are healthy, they just can't stretch enough to meet in the middle and close properly, so you get a leak back into the ventricle.
What causes the aorta to widen like that?
Typically things like chronic high blood pressure or certain connective tissue disorders like Marfan syndrome, Ehlers-Danlos, or Loeys-Dietz syndrome, which weaken the aortic wall. And importantly, that bicuspid aortic valve we keep mentioning. It's often associated with dilation of the proximal ascending aorta in up to 50% of patients. This can lead to AI at a much younger age than the stenosis we talked about earlier.
Okay. Another cause you mentioned was endocarditis, infection, right?
Yes, endocarditis. It's a relatively common and very serious cause of valve pathology, basically. An infection of the heart valves or the inner lining of the heart.
How does infection damage the valve?
It typically causes valvular insufficiency or leakage through progressive inflammatory destruction. The infection literally eats away at the valve tissue. Less commonly, the vegetations, which are these masses of bacteria or fungi mixed with platelets, fibrin, inflammatory cells, can actually grow large enough to obstruct the valve opening, causing a functional stenosis.
Who gets endocarditis?
It can affect previously normal valves, but it's more common in valves that are already deformed, maybe from congenital issues, rheumatic disease, degenerative calcification, or especially in patients who already have prosthetic valves. It usually affects the left-sided valves, mitral and aortic.
Is it always severe?
Acute endocarditis can be very aggressive, leading to rapid destruction, like perforation of a leaflet, causing sudden severe regurgitation. Chronic forms might result from slower infections or fibrotic healing after an infection. But even the more indolent forms carry a relatively high mortality rate compared to other valve lesions. It's always serious.
Okay, one last category, right-sided valve disease.
Right. Right-sided valvular disease. The most common issue here by far is functional tricuspid regurgitation, TR, a leaky tricuspid valve.
And functional means the valve itself is okay.
Usually, yes. It's typically secondary to problems on the left side of the heart. Left-sided failure leads to high pressures backing up into the lungs, pulmonary hypertension, which it then puts a huge strain on the right ventricle. The RV dilates, stretches the tricuspid annulus, and pulls the leaflets apart, causing the leak.
So it's a consequence of problems elsewhere.
Most often, yes. Less common primary causes of TR include endocarditis, especially in IV drug users, rheumatic disease, a rare condition called carcinoid syndrome, or sometimes iatrogenic injuries damage caused by medical devices like pacemaker or defibrillator leads that pass through the valve.
And tricuspid stenosis, narrowing.
Much rarer in developed countries, usually rheumatic in origin when it does occur.
Okay, so we know what can go wrong with these valves and the conditions that cause it. But, so what does this all mean? What actually happens to the heart and the rest of the body when these critical valves are compromised? And how does the body try to cope with such profound disruptions?
Yeah, this is where understanding the hemodynamic, the mechanics of blood flow becomes absolutely crucial. When a valve isn't functioning properly, the heart desperately tries to compensate to maintain adequate blood flow throughout the body despite the mechanical problem.
How does it do that?
Well, it depends on the problem. For stenosis, a narrowed valve, the hallmark is that the pumping chamber upstream of the valve has to generate significantly higher pressure to push blood through that narrowed opening.
More force needed.
A lot more force. This dramatically increases the afterload, that's the resistance the heart has to bump against. Imagine trying to force water through a tiny clogged pipe. You need way more pump pressure. This extra pushing also increases the wall stress on that particular heart chamber, making the muscle work much, much harder.
Okay, that's stenosis. What about insufficiency, the leaky valve?
For insufficiency or regurgitation, the hallmark is retrograde blood flow, backward flow.
Blood going the wrong way.
Exactly. Blood flows backward into the upstream chamber during the phase when the valve should normally be closed. So, for instance, in aortic insufficiency, blood leaks back from the aorta into the left ventricle after it's just been pumped out. This backward flow leads to volume overload in that upstream chamber. It's constantly receiving more blood than it should, the normal amount coming forward, plus the amount leaking back.
So pressure overload with stenosis, volume overload with insufficiency.
You've got it. And to cope with these immense stresses, whether it's increased pressure or increased volume, the heart employs two incredibly robust compensatory mechanisms. It's quite amazing, actually.
What are they?
The first is described by the Frank-Starling law, or the Frank-Starling mechanism.
Right.
This principle is basically the heart's way of saying, the more you stretch me with volume, the harder I'll contract.
Stretch leads to stronger pump.
Up to a point, yes. Imagine stretching a rubber band. The more you stretch it, the more forcefully it snaps back. That's essentially what happens with the heart muscle fibers, the sarcomeres. The more they're stretched by that increased blood volume at the end of filling, the more forcefully they contract, which helps maintain stroke volume, the amount pumped out.
Okay, Frank-Starling deals with volume. What's the other mechanism?
The second mechanism involves Laplace's law, and it explains how stress-induced ventricular hypertrophy helps.
Hypertrophy, the heart muscle getting thicker.
Exactly, thickening of the heart muscle walls. Laplace's law tells us that wall stress is related to pressure and radius, but inversely related to wall thickness. So by making its walls thicker and stronger, the heart can actually normalize the stress on its walls despite higher pressures or volumes.
So thickening reduces the strain.
It does. It reduces the tension on the individual muscle fibers, which in turn translates into decreased myocardial work and, importantly, decreased oxygen demand for a given level of pressure generation. It's a way to adapt to the increased load.
That sounds like a brilliant, almost miraculous compensation. The heart just adapts by pumping harder or getting thicker. But it can't last forever, can it? There must be a point where the heart simply gets exhausted.
Exactly right. While these compensatory mechanisms are incredibly effective, sometimes for many years they eventually get overwhelmed or become maladaptive themselves. They reach their limit, leading to significant cardiac problems and ultimately heart failure.
How does that failure play out for the different valve conditions? Let's start with mitral stenosis.
Okay, for mitral stenosis, MS, as the mitral valve narrows, normally it's 4 to 6 square centimeters, severe is less than 1.5, the resistance to blood flow from the left atrium to the left ventricle increases dramatically. This causes blood to back up and pool in the left atrium. LA pressure rises significantly. You start getting fluid in the lungs, pulmonary edema, when it hits around 25 millimillimary HD.
Pressure backs up into the lungs.
Precisely. This increased pressure transmits upstream to the pulmonary veins and capillaries, causing pulmonary hypertension, high blood pressure in the lung arteries. Over time, this places a huge burden on the right side of the heart, the right ventricle, RV. The RV can dilate, the tricuspid valve might start leaking, TR, and eventually you get RV failure or right heart failure.
So the problem starts on the left but ends up hurting the right side too.
Very common pattern. What's interesting about MS is that typically spares the left ventricle's pumping function initially. The LV is often small because it's starved of inflow, but it severely restricts how much blood can reach the LV.
So anything that demands more blood flow is bad.
Exactly. Any increase in cardiac output, like during exercise, or anything that decreases the diastolic filling time, like an increased heart rate, or the onset of atrial fibrillation, will make it even harder for blood to get across the valve, worsening the pressure gradient and symptoms. And that chronic pressure in the left atrium causes it to enlarge and stretch. This stretching can disrupt the normal electrical pathways, making atrial fibrillation very common, occurring in nearly 40% of patients.
The AFib is bad because...
Two main reasons in MS. First, loss of the coordinated atrial contraction, the atrial kick, which normally contributes about 30% of ventricular filling, causes a sudden drop in cardiac output. Second, the rapid, irregular heart rate drastically shortens filling time, worsening the stenosis effect. Plus, the stagnant blood in the enlarged LA increases the risk of blood clots forming, which can lead to stroke.
Okay, so MS affects the atria and right heart mostly. What about mitral regurgitation, the leaky mitral valve?
Right, mitral regurgitation, MR. Here, the consequences depend heavily on whether it's acute or chronic. In acute MR, say, from a ruptured chordae, the sudden massive backflow of blood floods into a small, unprepared, non-compliant left atrium. This causes LA pressures to shoot up dramatically.
Like a flash flood.
Exactly. That pressure is rapidly transmitted to the lungs, causing sudden, severe pulmonary hypertension and fulminant, often life-threatening heart failure and pulmonary edema. It's a true cardiac emergency.
Wow. What about chronic MR?
With chronic MR, the situation develops gradually. The left atrium has time to adapt. It dilates and hypertrophies, becoming more compliant. This allows it to accommodate the extra regurgitant volume without such drastic pressure rises. So patients can remain in a compensated state for many years, often without significant pulmonary hypertension. But that LA dilation itself often leads to atrial fibrillation and its associated risk of thromboembolism, just like in MS.
Okay, so the LA adapts. What about the left ventricle in chronic MR?
The LV faces volume overload. The blood leaking back from the atrium gets added to the normal inflow from the lungs. This increases the LV end diastolic volume, LV-EDV, the amount of blood in the ventricle just before it pumps. Initially, the LV compensates beautifully using the Frank-Starling mechanism. It pumps out a larger total volume. And because a significant portion ejects backward into the low-pressure LA, the ejection fraction, the percentage pumped out, can actually look supernormal early on.
So it looks like it's working great, even though it's leaking.
Exactly. It's deceptive. The LV also undergoes hypertrophy, thickening its walls, to normalize the wall tension from the increased volume.
But eventually...
Eventually, that compensation fails. A key sign of decompensation is when the ejection fraction starts to decrease, even though the afterload, the resistance to pumping forward, is actually reduced because it's easy to pump back into the LA.
So a falling EF is a bad sign here.
A very bad sign. It means the muscle itself is failing. Forward flow to the body decreases, LV-EDV continues to increase, leading to a vicious, self-perpetuating cycle of worsening heart failure, eventually LV failure, pulmonary hypertension, and right-sided heart failure.
Okay, let's switch to the aortic valve, aortic stenosis, the narrowed one. What happens there?
With aortic stenosis, AS, the narrowing of the aortic valve forces the left ventricle, LV, to generate incredibly high pressures to push blood out into the aorta and maintain cardiac output. This intense pressure overload induces significant concentric LV hypertrophy.
Concentric,
Meaning the walls thicken inwards, making the chamber itself smaller, but the muscle much thicker. Think bodybuilder muscles. New muscle units, sarcomeres, replicate in parallel. This thickening helps normalize the wall tension via Laplace's law, just like we discussed, and the heart can remain in a compensated state, preserving its pumping function, systolic function, for many, many years, often decades.
But that thick muscle must need more oxygen, right?
Absolutely, that's a major problem. About 2/3 of patients with severe AS develop myocardial ischemia, lack of oxygen to the heart muscle, which causes angina or chest pain even without blockages in their coronary arteries.
Why?
It's a mismatch. You have massively increased oxygen demand from the hypertrophied muscle working so hard. At the same time, the high pressure within the LV wall during diastole actually compresses the coronary arteries that feed the muscle, reducing oxygen supply. This combo can lead to heart muscle cell death, fibrosis, scarring, and eventually cardiomyopathy or heart failure.
So the thickening itself causes problems.
Yes. And another major issue with that thick, stiff LV is diastolic dysfunction. This often happens before the pumping function. Systolic function fails.
Diastolic dysfunction.
Yeah.
Trouble relaxing and filling.
Exactly. The stiff, non-compliant LV doesn't relax well. It takes longer to relax, and the filling period during diastole is shorter, especially at faster heart rates. This leads to higher pressures inside the LV even when it's filling, increased LVEDP. That high filling pressure backs up into the left atrium and then the lungs, causing pulmonary congestion, shortness of breath, and potentially pulmonary hypertension and right heart failure, even while the LV ejection fraction looks normal.
So symptoms can appear before the pump actually fails.
Very much so. But eventually, the LV does fail systolically too. It reaches maximal hypertrophy, can no longer generate enough pressure to overcome the stenosis, cardiac output falls, and you get overt systolic LV failure. The increased LA pressure and dilation in AS also raise the risk of atrial arrhythmias, like AFib, though maybe less commonly than with mitral disease. But losing that atrial contraction is particularly bad in AS because the stiff LV relies heavily on it for filling. Losing the atrial kick can cause a steep drop in cardiac output.
What about the fainting spells often associated with AS?
Right, pre-syncope, near fainting, and syncope,
Right.
fainting. This usually happens because of inadequate blood flow to the brain, often triggered during exercise or sudden position changes. The stenotic valve prevents the heart from increasing cardiac output sufficiently to meet the body's demands and maintain blood pressure, leading to reduced cerebral perfusion.
Okay, finally, aortic insufficiency. The leaky aortic valve.
Aortic insufficiency, AI. Again, we need to think acute versus chronic. In acute AI, maybe from endocarditis destroying the valve or an aortic dissection tearing the aorta, there's a sudden massive volume of blood leaking back into a small, non-adapted LV. The LV volume and pressure shoot up instantly. High LV EDP leads to immediate pulmonary edema, myocardial ischemia from poor coronary perfusion, and often rapid hemodynamic collapse or shock. It's a surgical emergency.
Chronic AI.
Chronic AI is much more insidious, often progressing silently for years. Here, the LV faces chronic volume overload from the regurgitant flow. To cope, the LV undergoes significant enlargement and eccentric hypertrophy.
Eccentric. How's that different from concentric in AS?
In eccentric hypertrophy, the muscle fibers elongate, and new sarcomeres are added in series, not parallel. This causes the chamber to dilate significantly, get bigger, while the walls also thicken, though perhaps not as dramatically relative to the chamber size as in AS.
Why does it enlarge so much?
This massive enlargement allows the LV to accommodate the huge regurgitant volume while maintaining a large forward stroke volume. It also helps decrease wall tension via Laplace's law again, bigger radius but also thicker wall, and preserve the ventricle's compliance, minimizing the rise in filling pressures early on. The body also helps by increasing heart rate slightly and decreasing peripheral vascular resistance, both of which reduce the amount of time for backward flow and make it easior to pump forward.
Is this where the corbovenum comes in?
Exactly. Ultimately, chronic severe AI can lead to the corbovenum, the cow heart. It's a dramatically enlarged heart, possibly with the largest end diastolic volume and mass of any heart disease. It can weigh up to 3 times normal, with a capacity maybe 4 times normal, just to handle those massive regurgitant volumes.
But like the others, this compensation eventually fails.
It does. Eventually, the continued volume overload leads to excessive dilation. Wall tension increases despite hypertrophy, driving up myocardial oxygen demand. At the same time, the low diastolic blood pressure, because blood is leaking back, and the high pressure within the LV wall impair coronary blood flow, leading to ischemia, fibrosis, cardiomyopathy, and overt heart failure. The limits of adaptation are finally breached.
It's clear these conditions are incredibly complex with such a wide range of impacts. For someone actually experiencing symptoms or maybe worried they might have a valve problem, how do doctors figure out exactly what's going on, and what does it actually feel like to live with these conditions as they progress?
Yeah, you're right. The diagnostic process is definitely multifaceted. It really combines careful listening to the patient's history and symptoms, a thorough physical examination, listening to the heart is still key, and then increasingly sophisticated imaging techniques. And as we've touched on, the progression of valvular heart disease is often insidious. It develops gradually, sometimes without clear symptoms for years. That's why we categorize it into clear stages, from stage A, at risk, right through to stage D, symptomatic severe.
Staging helps guide treatment.
Absolutely. And regular surveillance, most commonly with echocardiograms, ultrasound of the heart, is absolutely recommended to monitor the progression and guide timely intervention. The goal is to intervene before irreversible damage occurs, ideally not waiting until the patient is severely symptomatic or the heart function is already compromised.
Okay, let's walk through the main ones again, focusing on symptoms and diagnosis. What about mitral stenosis, MS? You called it a silent killer sometimes.
Right. Patients can be asymptomatic for many, many years. When symptoms do appear, they often include fatigue, dyspnea, shortness of breath, especially with exertion orthopnea, which is shortness of breath when lying flat, and eventually peripheral edema, swelling in the legs and feet from right heart failure. And as we discussed, any increase in heart rate, whether from exercise or the onset of AFib, will significantly worsen these symptoms by reducing filling time across the narrowed valve.
Are there other, maybe less common symptoms?
Yes, some more ominous signs. Thromboembolism, blood clots breaking off from the enlarged left atrium, occurs in about 20% of patients. And tragically, it can be the first symptom in 10%, presenting as a stroke or blocking arteries elsewhere. Rarely, a huge LA thrombus can actually block the valve itself, leading to sudden death. There are also some unusual manifestations from the sheer size of the enlarged left atrium. It can compress the nerve to the voice box, causing hoarseness, press on the esophagus, causing difficulty swallowing, or even compress airways, causing a cough. Hemoptysis, coughing up blood, can also happen from ruptured bronchial veins under high pressure.
Wow. What does the doctor hear on exam?
The characteristic finding is a low-pitched, rumbling, diastolic murmur. It's heard best at the apex, the bottom tip of the heart, often with the patient lying on their left side. In sinus rhythm, it often has presystolic accentuation, meaning it gets louder just before the next heartbeat. You might also hear an opening snap as the stiff valve tries to pop open, or the first heart sound might be louder than usual.
And tests, echo is key.
Echo is primary, yes. Echocardiography visually confirms the diagnosis. You can see the fused, immobile, thickened, often calcified leaflets. 3D echo gives even more detail. Doppler echo is crucial for assessing the hemodynamics. It accurately measures the pressure gradient across the valve using the Bernoulli equation and estimates the valve orifice area using various methods like planimetry or pressure half-time calculations.
What about other tests?
Chest X-ray can show signs of LA enlargement, pulmonary congestion like curly B lines. ECG might be normal initially, but often shows LA enlargement, P mitral, atrial arrhythmias like AFib, and signs of RV strain in advanced disease.
And the outlook, if it's not treated.
The natural history is quite telling. Asymptomatic patients have a pretty good 10-year survival, over 80%. But once symptoms develop in severe MS, patients who forgo intervention have less than 15% 10-year survival. And if severe pulmonary hypertension develops, the mean survival can be less than 3 years. It really highlights the need for timely intervention.
Okay, moving to mitral regurgitation, MR.
Yeah.
Acute versus chronic again.
Exactly. Acute MR is a crisis sudden, severe dyspnea, often hypotension or shock. Chronic MR, however, is often asymptomatic for long periods. When symptoms finally appear, there are typically the standard symptoms of left heart failure fatigue, shortness of breath, or the onset of atrial fibrillation, or eventually signs of right heart failure like swelling.
What's heard on exam for chronic MSR?
You might feel a hyperdynamic heartbeat, often shifted to the left. The classic murmur is holosystolic, meaning it lasts throughout the whole contraction phase, high-pitched, blowing, and heard best at the apex, often radiating towards the armpit. Though sometimes, depending on which leaflet is affected, it can radiate differently. You might also hear a diminished first heart sound, a widely split second sound, or a third heart sound, S3 gallop.
And diagnosis, echo again.
Echocardiography is absolutely the mainstay. It precisely visualizes the mechanism of the leak. Is it prolapse, a flail leaflet, billowing leaflets, annular dilation, a ruptured chordae or papillary muscle, restricted motion, or vegetations from endocarditis? Then, Doppler analysis provides crucial prognostic information by quantifying the leak. We look at the regurgitant jet, measure things like the proximal isovolumetric surface area, PIS, and the vena contracta, the narrowest point of the jet. These help calculate the regurgitant fraction, the effective regurgitant orifice area, EROA, and the regurgitant volume. Severe MR typically has a vena contracta greater than 7 mm, for example.
What's the outlook for MSR?
Acute MR is very poorly tolerated and often requires urgent surgery. Without it, patients can deteriorate rapidly. For chronic MR, even if it's severe but asymptomatic, and certainly for moderate primary MR, it carries a diminished prognosis with an increased risk of mortality over time compared to people without MENOS. And functional MR, the secondary type, generally has a significantly worse prognosis because it reflects underlying ventricular disease.
Right. Let's cover aortic stenosis, AS, the strain on the left ventricle. Symptoms.
AS typically has a long, asymptomatic latent period. Symptoms usually only appear when the valve area decreases significantly, often down to about 1 square centimeter. Normal is 3-4. The classic triad of symptoms when they appear are angina, chest pain, which is the presenting symptom in about 35% of cases, syncope, fainting, presenting in about 15%, and dyspnea or overt heart failure symptoms presenting in about 50%.
And the appearance of symptoms is a critical turning point.
Absolutely critical. Once any of these cardinal symptoms appear in severe AS, the average survival plummets dramatically if the valve isn't replaced. It's roughly 5 years after angina onset, less than 3 years after syncope, and only 1 to 2 years after heart failure onset. Sudden death is rare in truly asymptomatic patients, less than 1% per year, but the risk rises significantly once symptoms start.
What are the exam findings?
You might feel a forceful apical impulse, maybe slightly enlarged or shifted left if heart failure is present. The typical finding is a crescendo-decrescendo ejection murmur. It gets louder than quieter, best heard along the left sternal border, often radiating up to the upper right chest and into the carotid arteries in the neck. A thrill, a vibration you can feel might be present. And a characteristic finding in the carotid pulse is a slow rate of rise and reduced peak, the pulsus parvis et tardis. Chest X-ray might show a boot-shaped heart from the concentric LV hypertrophy, valve calcification, or post-stenotic dilation of the aorta. ECGs show signs of LV strain. But again, echocardiography is key. It gives precise assessment of the aortic valve anatomy, calcification, orifice size, planimetry. Doppler measures the transvalvular pressure gradients and allows calculation of the valve area using the continuity equation. Severe AS is generally defined by criteria like a peak velocity across the valve over 4 meters, a mean pressure gradient over 40 millimeter Hg, and a valve area less than 1.0 centimeter dose. Sometimes if the heart's overall pump function is low, the gradients might not look that high, even if the stenosis is severe. In those cases, a low-dose dobutamine stress echo can help assess the true severity. Cardiac catheterization is less common now for diagnosis, but still used in ambiguous cases, or to assess coronary artery disease, which coexists in up to 50% of AS patients needing surgery.
Okay, last one. Aortic insufficiency, AI, the heart's overload condition. Symptoms.
Acute AI often presents dramatically, sometimes masked by the underlying cause, like fever from endocarditis or chest pain from aortic dissection. Patients might have sudden dyspnea, hemodynamic instability, or shock. Chronic AI, however, is typically asymptomatic for years, even decades. When decompensation occurs, patients develop typical heart failure symptoms, angina, or sometimes just palpitations, especially during stress or exertion.
You mentioned chronic AI has lots of classic physical signs.
It does. Many relate to the wide pulse pressure, the difference between systolic and diastolic pressure, caused by the large stroke volume being ejected and then rapidly leaking back. You can get the water hammer pulse peripherally. Pulses rise abruptly and collapse rapidly. A bounding carotid pulse, Corrigan pulse. Head bobbing with each heartbeat, Demusset sign. Uvula pulsation, Mueller sign. Strange sounds over the femoral artery, Traub sign. Capillary pulsations visible in the nail beds, Quink sign. It's quite a collection.
And listening to the heart.
You feel a diffuse hyperdynamic apical impulse, often shifted down and left. The murmur is typically a high-frequency blowing decrescendo diastolic murmur, starting right after the second heart sound. It's best heard along the left sternal border with the patient sitting up, leaning forward, and holding their breath after exhaling. There might also be an Austin Flint murmur, a low-pitched diastolic rumble at the apex caused by the AI jet vibrating the mitral valve leaflet. The second heart sound might be soft or absent, and you might hear an S3.
Diagnostics.
Acute AI needs rapid diagnosis, often showing pulmonary edema on X-ray. Echo is definitive. Chronic AI shows a significantly enlarged heart on X-ray, the corbovenum, and maybe an enlarged ascending aorta. ECG shows signs of the increased LV mass and strain. Echocardiography is again comprehensive, evaluating the valve and root abnormalities, quantifying the LV size, function, and compliance, and assessing the regurgitant jet characteristics, jet width, vena contracta, regurgitant fraction, EROA, to determine severity.
And the natural history of AI.
Acute AI is a medical emergency leading to sudden heart failure. Chronic AI allows potentially decades of asymptomatic compensation. However, once the LV starts to significantly dilate, for instance, an LV end-systolic dimension, LV-ESD, greater than 50 millimeter, the combined rate of adverse events like death or need for surgery increases significantly, maybe 20% per year, even without symptoms. And once symptoms develop, mortality rates climb rapidly, often exceeding 10% per year without intervention.
Briefly, what about tricuspid regurgitation, TR?
Symptoms of TR are often hard to separate from coexisting left-sided disease, and it's frequently asymptomatic itself. Patients might have dyspnea, fatigue, exercise intolerance as right heart failure develops. The physical exam shows signs of central venous congestion, jugular venous distension, the prominent systolic V wave, maybe pleural effusions, an enlarged, sometimes pulsatile liver, abdominal tenderness, ascites, fluid in the belly, and peripheral edema. The murmur is holosystolic, heard along the sternal border, and classically increases with inspiration. That's Carvello's sign. Echocardiography is the sole reliable modality for assessing TR severity and mechanisms similar to mitral assessment. Estimating pulmonary artery pressure from the TR jet velocity is also important prognostically. An annular diameter over 40 millimeter indicates significant dilation. Natural history shows that survival decreases with increasing TR severity, regardless of other factors. Uncorrected moderate to severe TR carries a poor prognosis, with less than 50% survival at 4 years in some studies. And as mentioned, improvement after fixing left-sided valves is unpredictable.
Okay, so we've covered the problems, the consequences, the diagnosis. Now, the crucial part, treatment. Given these complex conditions and their often serious natural histories, intervention becomes paramount. What are the general philosophies behind treating valvular heart disease, and what does the modern toolkit offer, from medications to advanced surgery and those newer transcatheter techniques?
Right, the overarching goal in treatment is always multifaceted. Improve symptoms, absolutely, but also extend life and critically preserve cardiac function. And we always have to balance the risks of any intervention against the known natural history of the specific valve disease if left untreated.
So where do medications fit in?
Medical management plays a definite role, but it's crucial to understand its limitations. Medications are primarily supportive. They aim for symptom relief and managing comorbidities like hypertension or atrial fibrillation, but they are generally not curative for the underlying valve pathology itself. They don't fix the broken valve.
What kinds of meds are used?
Things like diuretics can help reduce fluid buildup and congestion, easing shortness of breath and heart failure. Beta blockers, or calcium channel blockers, might be used to control heart rate, especially important in mitral stenosis or if AFib is present. Anticoagulation blood thinners like warfarin or newer agents, NOACs, is essential for patients with AFib or a history of blood clots, guided by risk scores. For leaky valves like MR or AI, vasodilators might be used in acute situations to reduce afterload and the amount of regurgitant flow, making it easier for the heart to pump forward. Inotropes might be used for temporary support if the heart is very weak. However, there are some important caveats. For instance, beta blockers should be used with extreme caution in acute aortic insufficiency because they block the compensatory fast heart rate. And an intra-aortic balloon pump, often used for heart failure support, is contraindicated in AI because it would actually worsen the leak.
What about using meds to delay surgery?
That's a key point. For chronic conditions like severe MR or AI in patients who are asymptomatic and still have normal LV function, there's currently no evidence to support using vasodilators simply to delay necessary surgery. In fact, for primary MR, earlier intervention, even before symptoms or significant LV dysfunction develop, is often associated with improved long-term survival and better preservation of heart function. Waiting too long can be detrimental.
So medications are supportive, but surgery or other interventions are often needed to fix the underlying problem. Let's talk about traditional operative approaches, open heart surgery. How good are the outcomes now?
Generally, the outcomes for open heart valve surgery are excellent, both short-term and long-term for many patients. Operative mortality, the risk of dying from the surgery itself, is generally low, often less than 5% for most isolated valve procedures in otherwise reasonably healthy patients. We have sophisticated scoring systems like the STS score or Euroscore that help predict individual patient risk quite accurately based on various factors.
What are the main risks involved?
Like any major surgery, there are risks. Common ones include infection, wound infection or deeper infections, bleeding requiring transfusion, stroke, conduction problems that might require a permanent pacemaker, and perioperative heart failure. Long-term, patients with prosthetic valves face ongoing risks like thromboembolic events, clots forming on the valve, the need for reoperation if a bioprosthetic valve deteriorates over time, or if leaks develop around any prosthetic valve, perivalvular leaks, bleeding complications related to lifelong anticoagulation if they have a mechanical valve, and the risk of prosthetic valve endocarditis, that's serious infection.
How is the surgery actually done? Is it always the big chest incision?
Historically, yes. The standard approach was a full midline median sternotomy opening the breastbone down the middle. This gives wide exposure. However, over the last couple of decades, various minimally invasive approaches have become increasingly common for many valve procedures.
Like smaller cuts?
Exactly. Things like partial upper or lower sternotomies or small incisions on the right side of the chest, right thoracotomies. These approaches offer potential benefits like decreased need for blood transfusions, lower rates of wound infection and post-operative atrial fibrillation, sometimes shorter hospital stays, quicker recovery and return to activity, and improved cosmetic outcomes. The choice depends on the specific valve, the patient's anatomy, and surgeon experience.
But regardless of the incision, you still need the heart-lung machine.
For almost all open heart valve replacements or complex repairs, yes. The procedure requires cardiopulmonary bypass to circulate and oxygenate the blood, and cardioplegic arrest, temporarily stopping the heart with a special solution to allow the surgeon to work meticulously in a quiet, bloodless field.
Okay, let's get specific. Mitral valve replacement and repair. How is that done?
Exposure is usually gained through an incision in the left atrium or sometimes through the right atrium and across the septum dividing the atria, which gives excellent views. For mitral valve replacement, MVR, which is still the most common surgical management for severe mitral stenosis and some complex MR cases, a really critical detail is the importance of preserving the subvalvular apparatus.
Keeping the chordae and papillary muscles intact.
As much as possible, yes. We now know that preserving these connections to the ventricle is crucial for maintaining optimal LV geometry and function after surgery. It significantly improves both short and long-term survival compared to completely excising everything. The procedure involves minimal leaflet resection, careful sizing of the orifice, and then securing the chosen prosthesis, mechanical or bioprosthetic, with sutures around the annulus.
What about mitral valve repair? You said that's preferred for primary mitral heart.
Yes, when technically feasible, repair is definitely preferred over replacement for primary degenerative MR. It consistently provides improved quality of life, fewer valve-related complications, and improved long-term event-free survival. And modern repair techniques are highly durable, with less than a 10% chance of needing reoperation at 10 years in experienced centers.
What techniques are used in a repair?
A variety of techniques. If a segment of a leaflet is flail or prolapsing excessively, it might be resected, or for example, triangular or quadrangular resections, and the leaflet edges sewn back together. Sometimes relaxing incisions are made to reduce tension. A huge advance has been the use of artificial chordae, often made from Gore-Tex suture material. These neochordae are precisely measured and placed to provide appropriate leaflet support and prevent prolapse, allowing surgeons to preserve native leaflet tissue. And almost universally, a ring annuloplasty is performed in conjunction with leaflet repairs.
Putting in that supportive ring.
Exactly. It reshapes and stabilizes the dilated or distorted mitral annulus, the valve space, restores a more normal geometry, and ensures the repaired leaflets coapt, or meet properly, to prevent residual leakage. There's ongoing debate about the ideal type of ring, rigid versus flexible, complete versus partial, but the principle of annular stabilization is key. Annuloplasty can also sometimes be used as a standalone procedure if the only problem is annular dilation.
What about repairing secondary functional MR?
That's much more controversial. The debate between repair, usually just an undersized annuloplasty ring, versus replacement for secondary MR is ongoing. Some recent large trials have suggested that repair, while feasible, has significantly higher recurrence rates of moderate or severe MR compared to chordal-sparing valve replacement. And adding a repair to coronary bypass surgery didn't clearly improve mortality. So for severely symptomatic patients with functional MR and significant ventricular remodeling, chordal-sparing valve replacement might actually be preferred by many surgeons now. Newer techniques are also exploring ways to address the underlying ventricular and subvalvular distortion more directly.
Okay, let's move to surgical aortic valve replacement, SAVR and repair. How is that approached?
Exposure is typically via an incision in the proximal ascending aorta, just above the valve, often a transverse or hockey stick shape. SAVR is almost always required for symptomatic severe aortic stenosis. The procedure involves careful excision of the diseased, often heavily calcified native cusps. Thorough decalcification of the annular tissue is critical to allow secure seating of the new valve. Then either a mechanical or a bioprosthetic valve is implanted using sutures. SAVR offers excellent immediate and long-term outcomes, especially if performed before significant LV dysfunction develops. Sometimes, if the patient's aortic root is too small for an adequately sized prosthesis, the surgeon might perform a root enlargement procedure.
Is aortic valve repair an option?
Repair options for stenotic aortic valves are very limited, usually only feasible in select younger patients without calcification. Repair is more commonly performed for aortic insufficiency or in conjunction with surgery for aortic root aneurysms.
How does that work?
When AI is primarily due to dilation of the aortic root pulling the healthy leaflets apart, valve-sparing operations can be very effective. Techniques like the David procedure involve excising the diseased aortic root, tailoring a Deckrin graft, and meticulously reimplanting the patient's native aortic valve inside the graft, preserving the valve. These are complex operations but can yield excellent long-term results, avoiding the need for a prosthesis.
What about the tricuspid valve? You mentioned surgery is sometimes needed there too.
Yes, especially for functional TR that's severe and found during surgery for left-sided valve disease. As we discussed, the timing and method have been controversial. Historically, moderate TR was often ignored, hoping it would improve after fixing the left side.
But that doesn't always happen.
No, an uncorrected TR can progress, leading to irreversible RV damage and poor long-term outcomes. Current guidelines now give a Class I indication, meaning it's strongly recommended to perform concomitant tricuspid valve surgery if severe TR is present during left heart surgery. It's also recommended, Class I, for mild to greater TR if there's also significant annular dilation, over 40 millimeter, or signs of RV failure. And surgery is considered for symptomatic severe primary TR that's unresponsive to medical therapy.
Repair or replacement for the tricuspid?
Repair is generally preferred over replacement, especially for the common problem of annular dilation. An annuloplasty using a prosthetic ring to downsize and stabilize the annulus is the standard repair. Replacement might be considered if the leaflets are severely damaged, tethered due to RV remodeling, or if a prior repair has failed. If replacement is needed, bioprosthetic valves are usually preferred due to lower risk of thrombosis in the low-pressure right side compared to mechanical valves.
And tricuspid stenosis?
Rare, but medical management is usually ineffective. It's best treated with valve replacement, usually done concomitantly if left-sided surgery is also needed. Percutaneous balloon valvulotomy is an option, similar to mitral stenosis, but the results tend to be less optimistic.
This brings us to a really critical decision point in valve surgery, the choice of prosthetic valve. Mechanical versus bioprosthetic. Can you break down the pros and cons?
Absolutely. This is a complex decision with significant long-term implications for the patient. Let's start with mechanical valves. These are typically made from highly durable synthetic materials like pyrolytic carbon. Their major advantage is their extremely low rate of structural deterioration. They are built to last, potentially for the patient's entire lifetime.
Sounds great. What's the catch?
The catch is significant. They require lifelong anticoagulation, usually with warfarin, with strict monitoring of the INR level, a measure of blood clotting time. This is necessary to prevent blood clots from forming on the valve surface, which could lead to stroke or valve malfunction. This lifelong anticoagulation carries its own inherent risks, an estimated 0.6 to 2.3% annual risk of thromboembolic complications despite anticoagulation, and about a 1% annual risk of major bleeding complications from the warfarin itself. Adding low-dose aspirin might slightly reduce clotting events, but also slightly increases bleeding risk.
Okay, so durability versus bleeding clotting risk and lifelong medication monitoring. What about bioprosthetic valves?
Bioprosthetic valves, or tissue valves, are fabricated from preserved animal tissue, typically bovine, cow, pericardium, or porcine pig aortic valves, mounted on a stent frame. Their main advantage is that they generally do not require long-term anticoagulation beyond the initial 3 to 6 months post-surgery, unless the patient needs it for other reasons like AFib.
No lifelong warfarin. That's a big plus. What's the downside?
The downside is durability. Although modern anti-mineralization treatments have significantly reduced calcification and improved longevity, these valves do eventually wear out. Current generation valves show excellent durability, with maybe around 90% freedom from structural valve deterioration or needing reoperation at 10 years, especially in patients over 65. However, and this is key, failure rates due to structural deterioration are significantly higher and occur earlier in younger patients. This is thought to be due to greater hemodynamic stresses and higher metabolic rates, particularly calcium turnover, leading to earlier calcification and degeneration.
So the decision depends a lot on age.
Age is a primary factor, yes. Traditionally, mechanical valves were recommended for younger patients, for example, under 60-65, expecting a long lifespan, while bioprosthetic valves were favored for older patients where the valve might outlive the patient, avoiding anticoagulation risks. However, the lines are blurring. Given the risks and lifestyle constraints of lifelong warfarin, some surgeons and younger patients are now opting for bioprosthetic valves, accepting the higher likelihood of needing one or more reoperations later in life in exchange for avoiding anticoagulation. Other factors like likelihood of pregnancy, warfarin is dangerous in pregnancy, patient lifestyle, and absolute need for anticoagulation for other reasons also play a big role. It's a very individualized decision requiring thorough discussion.
Are there specific complications related to just having a prosthetic valve implanted?
Yes, a couple are worth highlighting. Prosthetic valve endocarditis, PVE, is a particularly dangerous complication. The risk is about 50 times higher in patients with valve implants than in the general population. It's an infection settling on the artificial material.
And hard to treat.
Very hard. It often requires complex re-replacement surgery, which carries a high mortality rate, potentially up to 40% at 1 year, even with aggressive treatment. Strict antibiotic prophylaxis before certain dental or medical procedures is critical for these patients. Another potential issue is patient prosthesis mismatch, PPM. This occurs if the implanted prosthetic valve is too small relative to the patient's body size and cardiac output needs. It results in residual pressure gradients across the new valve, impairing symptom relief and potentially hindering the recovery of LV function. It's less common with modern valves, and surgical sizing techniques and procedures like aortic root enlargement can sometimes prevent it.
Okay, that covers traditional surgery. But the really exciting area lately seems to be the less invasive approaches. Let's talk about transcatheter aortic valve replacement, TAVR, and other emerging technologies. What exactly is TAVR?
TAVR, sometimes called TAVI, transcatheter aortic valve implantation, has been truly revolutionary. It's a catheter-based procedure where a new bioprosthetic aortic valve, mounted on an expandable stent frame, is delivered via a catheter, usually inserted through an artery in the leg or sometimes the chest, and deployed within the diseased native aortic valve, essentially pushing the old leaflets aside.
So no open heart surgery, no heart-lung machine.
Generally, yes. It avoids the sternotomy and cardiopulmonary bypass. This technology has evolved incredibly rapidly since the first human implants in the early 2000s.
What is the evidence shown about TAVR versus surgical replacement, SAVR?
The landmark partner trials and subsequent major studies provided compelling evidence. Initially, TAVR was shown to be superior to medical therapy for patients deemed inoperable and non-inferior to SAVR for patients at high surgical risk. More recently, trials have extended these findings, demonstrating non-inferiority and in some aspects potentially even superiority for TAVR compared to SAVR in intermediate risk patients as well. This has led to expanded FDA approvals. Trials in low-risk patients have also shown favorable results for TAVR, further challenging SAVR's historical dominance.
This sounds like it's rapidly becoming the standard.
It's definitely transforming aortic stenosis treatment. A critical component of this has been the development of the multidisciplinary heart team.
What's the heart team?
It's a collaborative team involving interventional cardiologists, cardiac surgeons, imaging specialists, anesthesiologists, and others who collectively evaluate each patient and decide on the optimal treatment strategy, whether it's TAVR, SAVR, or medical management. This team-based approach ensures shared decision-making and is now being expanded to other complex cardiac conditions.
Has TAVR technology improved?
Massively. We have newer generation valves with lower profiles, smaller catheters, better sealing to prevent leaks around the valve, repositionable and recapturable systems, and improved deployment strategies. These innovations have significantly reduced complication rates like vascular injury and stroke compared to the early days.
Are there still limitations or concerns with TAVR?
Yes, there are still some important considerations. A major one is long-term durability. While intermediate-term data, around 5 years, looks promising for current valves, we still lack robust data beyond 10 years, unlike the decades of data we have for surgical valves. This is particularly relevant for younger, lower-risk patients who might need their valve to last 20, 30 years or more. TAVR also still tends to have slightly higher rates of needing a permanent pacemaker due to heart block compared to SAVR, and potentially higher rates of mild paravalvular regurgitation leaks on the valve, although newer valve designs are improving this. Mild leaks were initially thought benign, but may have long-term mortality implications. There have also been recent findings about subclinical valve thrombosis, small clots on leaflets, being more common with TAVR, although the clinical significance is still being studied.
So SAVR isn't obsolete yet?
Not at all. SAVR remains the gold standard for many patients, particularly younger, low-risk individuals where long-term durability is paramount, or those with complex anatomy unsuitable for TAVR, or those needing concomitant coronary bypass or other valve surgeries. The heart team approach helps navigate this choice.
What about similar transcatheter approaches for the mitral valve?
Percutaneous mitral interventions have generally lagged behind TAVR. The mitral valve's anatomy is much more complex and variable. The saddle-shaped annulus, the complex subvalvular apparatus, making catheter-based replacement or repair significantly more challenging.
But there are options, like the MitraClip.
Yes, the MitraClip system has gained the most traction. It was clinically introduced way back in 2003 and received FDA approval for high-risk patients with degenerative MR in 2013, and later for selected patients with secondary MR. It's a catheter-based clip system delivered through a vein in the leg across the septum to grasp and clip the edges of the mitral leaflets together, essentially emulating a surgical repair technique called the edge-to-edge or Alfieri stitch. It creates a double orifice valve.
How effective is it?
Studies like COAPT showed significant benefit in reducing heart failure hospitalizations and improving survival in specific, carefully selected patients with secondary MR who remained symptomatic despite optimal medical therapy. For primary degenerative MR, it's generally considered less effective at eliminating severe MR compared to surgical repair, but it provides a valuable, less invasive option for patients deemed too high risk for open heart surgery.
Are other mitral catheter therapies being developed?
Yes, research is very active. There are experimental therapies exploring indirect annuloplasty using devices placed in the coronary sinus, a vein near the mitral annulus, to cinch it down. Several dedicated transcatheter mitral valve replacement systems are also in clinical trials, adapting TAVR-like technology, but they face significant technical hurdles related to anchoring the valve securely in the complex mitral position. It's a rapidly evolving field.
What about patients with multiple valve problems,
Okay,
six-valve disease?
That presents really complex diagnostic and therapeutic challenges. There's unfortunately limited high-quality data to definitively guide treatment strategies when, say, both the aortic and mitral valves are significantly diseased. Therapy generally needs to be highly individualized, often targeting the hemodynamically predominant lesion, but always carefully considering the severity and impact of the concomitant valve disease on overall heart function and the patient's prognosis. It often requires intricate surgical planning if intervention on multiple valves is contemplated.
We've truly taken a deep dive into this fascinating world of acquired heart valve disease today. From the just intricate mechanics of these tiny structures working tirelessly inside us,
Billions and billions of
through
times.
the incredible leaps of medical science, constantly pushing the boundaries of what's possible to repair and replace them. It's really quite a story.
It is, and if we connect this back to the bigger picture, this journey really highlights a profound balance, doesn't it? You have the remarkable resilience of these biological systems, exquisitely designed to endure those billions of cycles, countered by the relentless, often silent progression of disease processes like calcification or rheumatic damage. And then, meeting that challenge, you have the persistent ingenuity of human innovation.
Yeah.
Think about the daring spirit of those early surgeons, literally working by feel, the scientific rigor that led to technologies like cardiopulmonary bypass, and now these mind-boggling transcatheter approaches. It's this ongoing dance between deeply understanding complex biology and then applying cutting-edge technology to intervene.
It really makes you think about how every single beat of your heart relies on these perfectly functioning gates. It's a small miracle, really, and how much dedication from doctors, scientists, engineers goes into preserving those miracles when things go wrong, pushing the limits of what medicine can achieve.
Absolutely.
So reflecting on this whole deep dive, what particular aspect stands out most to you? Is it the sheer volume of work our valves do without complaint? Or maybe those daring early surgeons you mentioned, literally putting their fingers inside a beating heart?
Both are certainly striking, but perhaps for me, it's also the ongoing ethical and clinical complexities we face now, like that crucial decision between a mechanical and a bioprosthetic valve, really weighing the lifelong burden and risks of anticoagulation against the near certainty of needing future reintervention, especially for younger patients. There's no single easy answer there.
That's true. It's a very personal choice.
It is, and it raises that important question. How much further can we push the boundaries of less invasive yet highly effective and durable cardiac interventions, especially for the more complex valves like the mitral and tricuspid where catheter therapies are still evolving?
And maybe looking even further ahead. Could we ever reach a point where we have truly bioengineered valves? Valves that could potentially remodel, grow, even heal themselves within the body, eliminating the need for replacement altogether.
That's the ultimate goal for many researchers, isn't it? A truly regenerative solution. Still seems like science fiction, perhaps, but given the progress we've seen just in the last few decades, who knows?
A powerful thought to consider. Well, thank you for joining us on this incredibly detailed deep dive into the heart's gates.
My pleasure. It's a fascinating topic.
Indeed it is. Until next time, stay curious and keep unpacking.